ADHD isn't just kids who can't sit still. For many adult men, it's a hidden force that shapes confidence, relationships, work, and, at times, life outcomes. Today we're going deep: what ADHD looks like at different ages, how it affects men's mental health, and what actually helps. Let's get into it. ADHD, Attention Deficit Hyperactivity Disorder, is a neurodevelopmental condition that affects attention, impulse control, and regulation of activity and emotions. Diagnostic checklists, DSM-5, require symptoms to be present across settings, to have started in childhood, and to cause real impairment. Adults are diagnosed with slightly different symptom thresholds than children. Prevalence and sex differences. Children and adolescents. Global reviews estimate childhood-adolescent ADHD in the ballpark of 5 to 8%. Adults. Large reviews estimate 2–4% of adults meet syndromic criteria, with broader symptomatic estimates sometimes higher, 3 to 6% depending on method. Sex ratio. Boys are more often diagnosed in childhood, commonly 2-3-1 male to female. But that gap shrinks in adulthood as inattentive presentations in females are recognized later. How ADHD changes with age. Age range breakdown. Preschool, approx 3–5 years. Typical presentation: very high activity levels, poor impulse control, short attention to structured tasks, trouble settling. Early signs can show in play and group routines. Mental health impact: early parent-teacher stress, discipline issues, risk of oppositional behaviors. Early help, behavioral parent training changes trajectory. School-age children, approx 6–12 years. Presentation: clearer academic inattention issues, forgetfulness, careless mistakes, classroom hyperactivity or daydreaming. Boys are more likely to be identified at this stage. Risks: school failure, peer problems, bullying, early conduct problems, co-occurring anxiety or learning difficulties are common. Early diagnosis plus school support is protective. Adolescence, approximately 13–17 years. Presentation shifts. Hyperactivity often morphs into internal restlessness. Academic and social demands increase and symptoms can become more impairing. Risk-taking increases. Mental health. Higher rates of depression, self-harm, and substance use begin to emerge in some teens with ADHD. 2/3 of children retain impairing symptoms into adulthood in many cohorts. Young adults, approx 18 to 25 years. Presentation: executive function demands surge. Managing college, work, finances. Problems with planning, time management, and relationships are typical. Mental health. This is a high-risk window for anxiety, mood disorders, substance misuse, and identity stress. Many men delay help seeking due to stigma. Adults, approx 25–64 years. Presentation: inattention often persists. Hyperactivity may appear as restlessness or impatience. Emotional dysregulation, mood swings, irritability, rejection, sensitivity is frequently reported. Functional impact: job instability, underemployment, relationship strain. Higher rates of co-occurring disorders, depression, anxiety, and risky behaviors unless treated. Older adults, 65+. Presentation and detection. Fewer studies exist, but ADHD symptoms often change with age and may be under-recognized. In some samples, symptomatic ADHD in older adults is non-trivial, estimates vary, and differential diagnosis versus cognitive aging is clinically important. How ADHD specifically affects male mental health, mechanisms, and outcomes. Masking and masculine norms decrease help seeking. Men are less likely to talk about emotions or pursue mental health care early, so ADHD often goes undiagnosed until crises. That delay raises risk for secondary depression, substance use, and relationship breakdown. Emotional dysregulation and rejection-sensitive dysphoria, RSD. Many men with ADHD report intense shame or emotional pain after criticism or rejection. RSD is widely described in specialist clinics and patient literature, not a formal DSM diagnosis but clinically reported. This amplifies depression and social withdrawal. Higher risk behaviors and comorbidity. ADHD raises the chance of substance use disorders, risky driving, and impulsive decisions, all of which harm mental health and life expectancy. Meta-analyses and cohort studies show elevated comorbid mood disorders and SUD in ADHD populations. Suicide and mortality signal. Multiple reviews and cohort studies find ADHD is associated with elevated suicidal behavior and, in population data, with shorter life expectancy, linked to accidents, health behaviors, and untreated mental illness. These are important and actionable public health findings. Neurobiology and why ADHD affects mood and behavior. ADHD involves differences in brain networks for attention, reward processing, and executive control, dopamine and frontostriatal circuits, which link directly to difficulties with planning, delay tolerance, and emotional control. That neurobiology helps explain persistent low motivation, mood lability, and impulsivity. Diagnosis: what to expect, brief clinical primer. Screening tools commonly used: ASRS, Adult ADHD Self-Report Scale, and CAARs, Connor's Adult ADHD Rating Scales. These are screening aids, not standalone diagnoses. A formal diagnosis uses clinical interview, developmental history, and collateral information, childhood symptoms, school reports, and follows DSM-9 recommendations. Important note, adults require fewer symptoms on DSM-5 instead of 6, and clinicians must rule out other explanations, e.g., mood disorders, substance effects. Treatment evidence and practical options, what helps? 1. Medication, stimulants and non-stimulants. Stimulants, methylphenidate, amphetamines, are the most strongly evidence-backed for core symptom reduction across ages. Meta-analyses show robust effects. Side effects and cardiovascular risk must be assessed and monitored. Recent large observational work suggests medication is associated with reductions in harmful outcomes, suicidal behavior, accidents, substance misuse, though observational designs have limits. Non-stimulants, e.g. atomoxetine, guanfacine, are alternatives when stimulants aren't suitable or tolerated. Guidelines, NICE, outline when these are appropriate. 2. Psychotherapy and skills work. Cognitive behavioral therapy, CBT, adapted for adult ADHD shows medium to large effects on symptoms and functioning in meta-analyses and reduces depression anxiety when targeted. ADHD coaching and structured skills training, planning, time management, reminders, improve everyday functioning. Evidence is emerging and often best used alongside clinical treatment. 3. Environmental and workplace education supports. Reasonable adjustments, quiet workspace, flexible scheduling, written instructions, assistive tech, reduce failure and stress at school, work, and are an important part of management. Employers have legal duties in many countries to consider adjustments. 4. Lifestyle and self-care. Sleep, regular exercise, structured routines, reducing alcohol and stimulant misuse, and stress management. Mindfulness, scheduling, all support medication and therapy outcomes. Many services, NHS, CHADD, recommend multimodal approaches. Safety and monitoring, honest talk. Medication is effective for many but needs medical review, blood pressure, heart history, and monitoring for side effects. Some long-term observational papers signal small cardiovascular risks and stress the importance of monitored prescribing. Untreated ADHD combined with depression, substance use, or social isolation is what raises the most serious risks. So early, combined support is protective. Recent large registry studies show medication periods correlate with reduced rates of suicide attempts and some harms, but treatment must be tailored and monitored. Practical advice for men watching, clear, actionable. If you suspect ADHD and it's affecting work, relationships, or mood, get a screening, ASRS, and talk to a GP or mental health clinician. If you're feeling overwhelmed, depressed, or having suicidal thoughts, seek help immediately, local emergency services or crisis line. In the UK, Samaritans 116 1E3. Ask about multimodal care, medication, if appropriate, plus CBT skills training, plus workplace school adjustments, plus coaching support groups. Small changes that help now: use timers, single tasking blocks, a visible planner, remove non-essential distractions, schedule tough tasks for your best time of day. Practical, evidence-informed tactic. Myth busting. Myth: ADHD is just kids being naughty. No. It's a persistent neurodevelopmental condition with measurable effects on cognition and behavior. Myth: medication fixes everything. No. Medication helps core symptoms, but best outcomes come from combined approaches, therapy plus practical supports. Closing thoughts on the deep dive into this topic. If you learned something or this rang true, please share this video with someone who might benefit. If this is about you, you're not failing. You're facing a treatable condition and help can change outcomes. Links to screening tools, NHS CHADD resources, and key studies are in the description. If you're in immediate danger, call your local emergency services. See you all next time.